Hey everyone, Ryan here, and welcome back to our series on prosthodontics. Like all my videos, I'm going to be focusing only on the highest yield things you need to know for the exam. And I know we already talked about the basics of occlusion in our second video of this series, but here we're going to look more into the occlusion for complete dentures. And understanding a patient's occlusion is critical to making a proper denture. So if you haven't watched the first two videos in this series, I highly recommend you check those out first because I'll be using a lot of the terms in this video that I introduced in those. So there are basically three really important measurements to know for complete dentures. That is VDO, VDR, and interocclusal rest space. So the first one we'll talk about is vertical dimension of rest, which is VDR, and it's shown in yellow in this image. So the vertical dimension of rest is the distance measured between the nose and chin at rest. Now sometimes it's measured using other points, but the most stable points of interest would be the tip of the nose and the tip of the chin. So those are typically used for measuring the distance. And it's not only the distance between the nose and the chin, but it's at rest, and specifically where elevator and depressor muscles are in a state of equilibrium. And this is sometimes called physiologic rest position, or PRP for short. So if you're just relaxing your jaw, if you swallow and maybe slightly open your mouth, that's sort of the most relaxed position for you. That would be your vertical dimension of rest. And so this is for edentulous patients, this is for dentate patients. Everyone has a vertical dimension of rest. And in this position, there is usually, if you have teeth, 3 millimeters of space between the upper and lower premolars. And that number will become important a little bit later. So let's just say for this patient, when he's at rest, distance between tip of chin and the tip of the nose is, let's say, 10 centimeters. All right, so VDO stands for vertical dimension of occlusion. And that's the distance, again, between the nose and the chin, but when the patient is biting together. And that's where the occlusion comes in. And that's going to be represented with the white arrow in this image. So it indicates the superior-inferior relationship of the maxilla and the mandible when the teeth are occluded in maximum intercuspation. Remember, MI was one of those key occlusal positions that we talked about in our very first video. So you can imagine how the vertical dimension of occlusion would be very different if, say, the patient has teeth versus if they're missing posterior teeth or don't have any teeth at all. So let's just say for this patient, it's 9.5 centimeters. And you can imagine that when this patient bites together, the tip of his chin gets up to this line here. So this is showing his vertical dimension of rest. And you can imagine, again, if he was biting together, his chin would get maybe up to this level. So that would mean the vertical dimension of occlusion, again, is maybe, let's say, 0.5 centimeter shorter for this patient. And so that leaves us with the final measurement. That's the interocclusal space. And that's the difference between these two distances. That is VDR and VDO. And it's ideally 2 to 4 millimeters. And that's where that 3 millimeters comes from. That was usually 3 millimeters of distance between the upper and lower premolars when a patient's at rest. And so we can get this equation that's vertical dimension of rest is equal to the vertical dimension of occlusion when the patient's biting down, plus about 3 millimeters of interocclusal rest space, which would be the distance between these two positions. And this is an ideal scenario, so it varies depending on the type of patient you're working with. So in our example, we said vertical dimension of rest would be 10 centimeters, and the vertical dimension of occlusion would be 9.5 centimeters. So the distance between those two, or the difference rather between those two, would be 0.5 centimeters or 5 millimeters. So you may be thinking, well, okay, that makes sense, but what if the distance between the two is too large or too short and is way far away from this 3 millimeter mark? So we'll talk about that right now. So let's say we have excessive VDO. That would be where the interocclusal space is less than 2 millimeters. Or maybe even the VDO is bigger than the vertical dimension of rest. So this would cause a whole bunch of symptoms: excessive display of mandibular teeth, muscles of mastication being fatigued, and that's a really important one to know for the exam, clicking of the posterior teeth when speaking, strained appearance of the lips, as you can see in this image. The patient would be unable to wear the dentures due to discomfort, excessive trauma to supporting tissues, and gagging. So this is a whole host of issues if you have an excessive vertical dimension of occlusion. So this would be if you made a set of dentures for a previously edentulous patient and the dentures are just too tall and they're causing the patient to have to stay more open than they would be at rest. And so this is causing a lot of strain on the tissues and discomfort for the patient. Now, how about the opposite problem, having an insufficient vertical dimension of occlusion? This would be where the interocclusal space is greater than 4 millimeters. And the patient has a long distance of closing between vertical dimension of rest and vertical dimension of occlusion. So, for example, this could be a patient that just doesn't have any dentures and is missing all their teeth. So they have an extreme loss of vertical dimension of occlusion because they have no teeth to bite down on. So this can lead to a couple things: an aging appearance of the lower third of the face because of thin lips, wrinkles, the chin being too near to the nose, overlapping corners of the mouth, and all of these things that would lead to someone looking a little bit older. A diminished occlusal force, and angular colitis, which is that could be fungal infection, bacterial infection at the corner of the mouth. And so this is, again, due to this overlapping corners of the mouth with insufficient VDO. And so this folding in the mouth is just a perfect opportunity for an opportunistic infection like Candida to take over and cause angular colitis. All right, so we have all that information. Now, what can we do with it? So the CR record is something we talked about again in our previous video, so definitely check out those first 2 videos of this series if you haven't already. But for an edentulous patient, the CR record provides the ability to increase or decrease the VDO more accurately in the articulator by establishing a radius of the mandible's arc of closure. Alright, so what does that mean? Well, in other words, if the VDO is incorrect, like we just talked about in the previous 2 slides, you can change this by mounting the casts using a CR record, which, remember, is all about the patient's condyles. The MI record and the MI position is all about the teeth coming together, whereas the CR, the centric relation record, and that position is all about the condyles being at home in their fossa. So by mounting the casts using a CR record and then manipulating the guide pin on an articulator can lead you to changing the VDO. And so you can do that in order to adjust if a patient is having an excessive VDO problem or an insufficient VDO problem. And this is just review from our second video, but the FACEBO again is critical for giving us information about where the maxilla is relative to the hinge axis, that is the axis of rotation at the temporomandibular joints. So the CR record and FACEBO together, again, are those critical diagnostic pieces of information that we need to create and fabricate a proper set of dentures for that specific patient. Now we also have a certain record called the Protrusive Record, and this one registers the anterior inferior condyle path in the translation movement of the condyles. So in other words, when the patient moves the mandible forward, the condyles slide down their articular eminences. This is that translation movement that I've talked about in my occlusion videos. And so the protrusive record is capturing this dynamic movement of the mandible forward and down. So we have this phenomenon, which is definitely going to be tested on the board exam, called the Christensen's phenomenon. And it refers to the distal space created between the upper and lower occlusal surfaces when the mandible is protruded due to downward and forward movement of the condyles down their articular eminences, like we talked about with the whole protrusive record. So another way to think about this is a posterior open bite is formed as the patient's mandible slides forward, like you can see in this image. There's separation or disclusion of the posterior teeth as the patient slides their jaw forward, because the condyles don't just go straight forward, they come down and forward. And so that's opening up this posterior space. Now, if you're talking about complete dentures, this could lead to possible instability. And so there's this thing called compensating curves that could be built into the denture to compensate for that. And so we're going to talk about that more a little bit later in this video. It's super cool to think about. And this is just a sneak peek of how the compensating curve would work. It sort of, instead of keeping the denture flat across like this horizontal line, you can curve the teeth back and up as you go posteriorly, so that as the patient's sliding forward, all the teeth remain in contact. But again, I'll talk about that a little bit more in later slides. All right, so let's talk about the plane of occlusion and how we can measure that for a patient receiving dentures. So the Camper's line is an imaginary line from the ala of the nose, that's the side of the nose, to the tragus of the ear, which is that little part of skin that sticks out from your outer ear. And so if you draw an imaginary line, that would be your Camper's line. And so if you remember ala of the nose, tragus of the ear, that would be something that again could be tested on the board exam, as could the interpupillary line, which conveniently is just an imaginary line between the pupils of the eyes. So inter and pupillary, meaning between the eyes, or the pupils of the eyes. So the maxillary occlusal wax rim should be parallel to both of these lines. So maxillary occlusal wax rim, what's that talking about? Well, I'm going to talk a little bit more about this in the next video, but the occlusal wax rim is what you would make after taking your impression, and what we would use to measure the maxillomandibular relations. That's that whole MMR thing that we talked about again in our introductory videos. And you would measure the MMR and guide the lab technician where to place denture teeth in the trial denture. So this is a really important, this is just a nice clip art picture of what a wax rim would be. Patient would try it in, and we'd be able to see where that patient's Camper's line, interpupillary line would be, and we want to try to keep that maxillary wax rim parallel to both of those lines if possible. And we can measure this with this metal instrument called a Fox plane. All right, so balanced occlusion for complete dentures, it refers to simultaneous anterior and bilateral posterior contacts, a phenomenon known as tripodization, in centric and eccentric movements to maintain seating of the dentures. So tripodization is an important concept, and it involves, again, contacts that are simultaneous in the front, so anterior contacts, and contacts on both the patient's right and left side. When the patient's both biting down, that would be eccentric, and when they slide the mandible around, front, back, sideways, that is eccentric movements. So we're getting this tripodization where all points of the denture, both front and both sides of the back, are contacting all at once. So again, that concept of the Christensen's phenomenon is ideally not occurring with dentures because we want to maintain contact as the patient slides around so the dentures are being stable in place and there's a constant force that's on them at all times. So that's what balanced occlusion is talking about, having balance between those all different points of the denture so that one side of the denture is not getting more force than the other side, which could cause it to dislodge. The front's not getting more force than the back, which would cause it to dislodge, etc. So anterior guidance, however, should be avoided in complete denture occlusion to prevent dislodgement of the denture bases. So this is an important distinction here because we like to have simultaneous anterior and bilateral posterior contacts in centric and eccentric. However, we don't want anterior guidance because this could cause dislodgement. This would be, we talked about it in one of the previous videos, anterior guidance referring to incisal guidance and canine guidance. So anterior guidance is an umbrella term that includes both incisal and canine guidance. And this makes sense, right? Because anterior guidance is focusing only on the incisors and the canines. And if those are the only teeth in contact, well, the posterior teeth would be discluded. And so now we have an unbalanced occlusion on the dentures. There would be more contact on the anterior teeth than the posterior teeth, and we could have the dentures flip and dislodge. So we want to avoid that and instead have a nice balanced occlusion. So on the balancing side and on the working side, these are terms that are referred to in my dynamic occlusion video. So I will leave a link to that in the description where we talk all about this type of working and non-working movement. So if you'd like to learn more about that, definitely check out that video. I'll leave a link in the description. All right, so we had this balanced occlusion concept. Now let's talk about lingualized occlusion, which is another sort of occlusal scheme. These are all occlusal schemes used in denture fabrication and tooth setting and tooth position. And so lingualized occlusion is another one just to be familiar with. So it's where only the palatal cusps of the maxillary posterior teeth contact the mandibular posterior teeth, theoretically eliminating destabilizing buccal force vectors. So you probably don't have to know too much about the details of this. There's all this neutrocentric occlusion and all of that. I think the only thing you would need to know for the board exam with lingualized occlusion is that it's all about, here's the upper teeth and the lower teeth, and this is from sort of a coronal view. This would be the palatal cusp of the upper posterior tooth, and it's contacting in the central fossa or marginal ridges of the lower posterior teeth. And that is the only contact that we want in lingualized occlusion. So the lingual cusp of upper teeth into the lower fossas and marginal ridges being the only point of contact, which could create a very simple and stable force vector to avoid, again, we're just trying to avoid dislodging of the dentures during function. So we have balanced occlusion, which is all about tripodization, and we have lingualized occlusion, which is all about upper palatal cusps being the only point of contact. And that's really the gist of it. That's the most important stuff I would take away from balanced and lingualized occlusion. All right, so before we end the video, I'll talk about these Bennett concepts. There's some distinctions that are important with the different Bennett terms, and then we'll end talking about determinants of occlusion. And that'll basically wrap up the very complicated and somewhat dry concept of occlusion. So I'm hopefully helping you understand some of this. I know it's a little bit dry and can be a little bit wordy, but we'll mostly focus on the highest yield information for the Bennett stuff. So Bennett angle is the angle obtained after the non-working side condyle has moved anteriorly and medially relative to the sagittal plane. So let's get familiar with this image because it'll really help us understand these concepts. So this is an aerial view of the mandible. We're seeing the two condyles, which have been sort of isolated from the rest of the mandible. And you can see this darker gray part is the mandible's start position, and the lighter gray portion is the mandible's end position after having moved forward and to the right. So the patient is moving the mandible to the right, which means that the right side is the working side, and that would mean the left side is the non-working or balancing side. So if the patient is moving to the right, that means that the right side is working side and their left side is their non-working side. Okay, so a Bennett angle is all about the non-working side. So for this patient, it would be their left condyle since they're moving to the right. So the Bennett angle is shown here on the left condyle. It's this angle that has been formed as the condyle has moved to the right and has moved forward. So remember, the standard for Bennett angle is about 15 degrees. That's sort of the universal standard for setting on that semi-adjustable articulator that we had talked about before. Now, Bennett shift is the lateral movement of the mandible toward the working side during lateral excursions. I'll go ahead and read the next one as well. Bennett movement is lateral movement of both condyles toward the working side, basically temporomandibular joint looseness. So some sources use shift and movement interchangeably, or use the collective term lateral side shift to refer to both the bodily movement of the mandible and its two condyles. So this picture shows both the angle, the Bennett angle, which is on the non-working condyle, as well as the shift or movement, which is evident on both condyles, but Bennett movement is only evident, or the Bennett angle is only on the left, movement's on both, but you can really appreciate this lateral side shift for the working condyle as the mandible is moving to the right. So I don't think there has to be a distinction for your studying on the board exams. So, because some sources say this is only the shift is due to bodily movement and the movement is from condyles, and I've seen it the other way. So I would just remember angle being for the non-working condyle, shift and movement referring to the whole mandible just moving towards the working side, including the condyles. All right, so lastly, here we are, determinants of occlusion. And so this slide is an awesome reference slide for you. I really highly recommend checking this out, pausing the video, and writing all this stuff down. And the factors that favor disclusion, that would be no eccentric contacts or the separation of posterior teeth. And the posterior teeth separate quickly when leaving maximum intercuspation. So these are all the determinants of disclusion and factors that favor disclusion. So you can think about that Christensen's phenomenon, that quick separation of teeth from each other. These are all things that can be built into a patient's anatomy or can be controlled based on their teeth with fixed prosthodontics, removable orthodontics, things that we can control for the most part in order to favor disclusion. So again, this is a great reference slide for boards, and I highly recommend you memorize all of these at your convenience, of course. So the first thing we'll talk about is anterior guidance. Again, that's that incisal and canine guidance kind of stuff. And so in the horizontal dimension, that would be protrusive movement forward, we'd want a steep incisal guidance. And that makes sense because a steep incisal guidance will separate the teeth quickly. In the lateral direction, that would be excursive movement to the right and left, we'd want steep canine guidance because, again, that will separate the teeth quickly. All right, cool. So that makes sense. Now, how about for posterior guidance? Well, we have some things that we've already covered. And in the horizontal direction, again, that's protrusive movement forward, we'd want a steep horizontal condylar inclination. That would be the condyles sliding down their path along the articular eminences. In the lateral direction, we'd want less Bennett movement. That's that lateral side shift we talked about towards the working side. So we'd want less of that in order to favor disclusion. For cuspal anatomy, we'd want short cusps with shallow inclines. And this one may be counterintuitive at first because we've all been talking about, for the most part, steep sort of things, and now we're talking about shallow inclines. But short cusps with shallow inclines, well, that was true for the anterior teeth having steep inclines, but for the posterior teeth, we want short, stubby cusps because then they will disclude or separate from each other faster. So we want the steep cusps for the front teeth that can provide anterior guidance, but shorter cusps for the posterior teeth will be able to separate from each other much quicker. So again, these are all the factors favoring disclusion, so that would make sense there. Now, tooth arrangement is referring to the compensating curves that I mentioned about. So less curve of Spee and less curve of Wilson. They're both compensating curves, and well, let's dive a little bit more into those specifically. So the curve of Spee is the antero-posterior curve to ensure loading into the long axis of each tooth. So it's shown in lime green here, and as you go back posteriorly, there's more mesial inclination of these bottom teeth. So you can see how they start sort of, straight up and down, and as you go back, these molars start to tip more mesially. So this premolar is like this, the long axis of this one goes here, long axis of this one goes here, and so on. So they kind of tip more and more mesially, and this creates a favorable loading into the long axis of the teeth. So that was from the side view. Now from our coronal front view, the curve of Wilson is the mediolateral curve along posterior cusp tips, but to do the same thing to ensure loading into long axis of each tooth. So now, instead of more mesial inclination, we're having more lingual inclination as you move distally. So that means some of the teeth in the front, the premolars are tipped more this way, and then as you move posteriorly, they tip more to the lingual. And this creates this kind of smiley face arc in this direction. So those are our two compensating curves. So to have less of these compensating curves, having more flat across horizontal arrangement of teeth, again would lead to that Christensen's phenomenon. You'd have a faster separation of the teeth. So you could provide more or less curve depending on what kind of occlusion or disclusion you wanted for your dentures. So again, having less of a curve and having a straight across occlusal plane will allow the teeth to separate from each other more than if you had them tilted and sloped. And lastly, we want to talk about the orientation of the occlusal plane. And this is different from the compensating curves because we're comparing the orientation of the occlusal plane to the orientation of the condylar path. So we want the occlusal plane, if we're going for disclusion, to be less parallel to the orientation of the condylar path. So let us draw a quick sketch here, if we had the occlusal plane, let's say, was pretty flat, we had a very minor curve of SPE going posteriorly, and the horizontal condylar inclination was something like this, let's say. So the condyle is moving down this way, and so the teeth would be discluding, in this sort of direction. So having a less parallel or more perpendicular occlusal plane to the condylar path would have more disclusion, since the condyles will slide down at a steeper angle relative to your occlusal plane. So a situation that was like this would disclude not a whole lot, because you're having the condyle slide down at a similar angle that the teeth would slide down each other. Whereas if you had something like this, where the two angles are more perpendicular, closer to being perpendicular than parallel, you'd have more disclusion. And on this slide, I'm not going to go through it because it's basically just the opposite. This would be all the factors that favor eccentric occlusion on posterior teeth. That is, posterior teeth separating slowly when leaving maximum intercuspation. So this is everything exactly opposite to what we just learned. So for your board studying, you really just have to pick either this slide or this slide to memorize, because as long as you know one of them, you know that the other is true for all of the opposite factors. So again, having more or less of a certain determinant of occlusion depends on the type of occlusion you want. If that patient is, if they had a full mouth rehabilitation with a bunch of crown and bridge work, if they have complete over complete dentures, it depends based on the situation of the patient and what they're going for, what kind of occlusal scheme, whether you want balanced occlusion, whether you want lingualized occlusion, and whether you'd want to favor disclusion or maintaining as much eccentric occlusion as possible. All right, so hopefully that video is helpful. I know some of those things got pretty complicated pretty quickly, but hopefully having that reference slide to go back to will really help you in your studies. Thanks so much for watching, everyone. I hope you enjoyed this video, and we'll see you all in the next one.